Here we have MRI of the lumbosacral spine in a 40-year-old with history of subacute back pain not responding to treatment. We have got sagittal T1, T2 and stir sequences. I'm not showing the axial sequences because that is not important for this discussion. So what we have got here is significant abnormal signal at the L5S1 end plates. We see low signal intensity on T1, increased signal intensity on T2 and stir sequence. So these findings are most likely to represent modic type 1, that is inflammatory type of degenerative change. In addition, we have got a small nodule in the superior end plate of the S1 with herniation of the nucleus pulposus into the small nodule. There is also annular fissuring, which you can see both anteriorly and posteriorly on both T2 and T1 sequences. A differential would include a subclinical discitis, but this is unlikely because the end plates remain intact and smooth. There is no evidence of erosion, irregularity, or destruction of the end plate. And also, there is the anterior and posterior cortex appear intact. There is no epidural or prevertebral soft tissue. On the axial, there was no paravertebral soft tissue as well. In addition to that, we need to look at other findings quite carefully. If we look on T1 sequences, the anterosuperior and anteroinferior corners of the vertebral bodies show increased signal intensity. Similarly, they show increased signal intensity on T2 as well. But when we go on the sagittal stir, few of them show low signal, but few of them show increased signal. With these findings, along with the L5S1 end plate degenerative changes, we need to now start considering could this be inflammatory arthritis. So we need to go to the edges of the film on the lumbar spine and we can see there is abnormal signal on both sides of the edge of the images, especially on the sagittal stir sequences, which is highly indicative of active bilateral sacroiliitis. So now, combining all three features, that is modic type 1 end plate degenerative changes, uh, both active and inactive inflammatory corners in the vertebral body edges, and high suspicion of bilateral active sacroiliitis features are very likely to represent active inflammatory spondyloarthropathy, such as ankylosing spondylosis or secondary to known inflammatory bowel disease. This patient did not have any past history of inflammatory bowel disease, hence, the findings are highly indicative of active ankylosing spondylosis. In summary, I am showing this patient not to overdiagnose modic type 1 as subclinical discitis, and also when we see modic type 1 degenerative changes we should be looking carefully at the corners of the vertebral bodies on all sequences and also on the edges of the films to look for sacroiliac joint abnormality.